Thank you, Mr. Chairman. And I would like to thank organizing committee to invite me to debate the hot topic of I think in this moment. TAVI is for all aortic stenosis patients. I would say yes. This topic is quite very difficult for me to talk among the great surgeon here because I am a cardiologist interventionist. So we talk in the atmosphere of the surgeon. I would say first that really the surgeon is our best friend, not enemy. We work together. Yeah, in our hospital we work together as a heart team. We come for helping surgeon reduce your workload and shorten your patient's waiting list. I will show you later what is true. As you know that the aortic stenosis, the treatment is standard treatment in the previous era is surgical AVR. And when the patients develop symptoms, the prognosis is getting worse, but particularly when he or she has the heart failure, 2-year average survival. And this is the conventional treatment in the past. And the patient will end up with a surgical scar in the midline sternotomy. This is the first time we introduced the TAVI by Professor Alan Kibier. You see that when he finished the procedure, maybe he can say hello to the patients. It means that the recovery is very, very fast. In the first case, you see that it's go into the femoral vein and transeptal puncture and cross the mitral valve and aortic valve, go to the ascending aorta. This technique now is absolute. No one do the technique like this. In the TAVI era, so far, the most common used platform of the TAVI is a balloon expandable sapien valve from the Edward. And another platform is the self-expandable. The pioneer is the core valve. This is a little bit different between self-expandable and balloon expandable. Anyway, the outcome is not so much different. We need the transfemoral approach or transapical approach if transfemoral cannot access. As well as the self-expandable, we can go with the transfemoral subclavian, or sometimes we go with the direct aortic. This is the access size. We prefer transfemoral approach if possible. And now the delivery system is quite small. We can go with the 14 French and go very easy. Start with the first randomization for the TAVI. The partner study design. They enrollment the patients who have high risk, severe aortic stenosis, or inoperable patients. The surgeon don't want to operate anymore. Then they divide into two arms. One is the inoperable arm, and randomized to TAVI or standard treatment that include the BAV balloon aortic valve angioplasty, and it is usually treatment like palliative treatment. The endpoint of this arm is all-cause mortality. And, this is the design as the superiority trial. For the high risk, they randomize 1-to-1 with TAVI and or surgical AVR and divide into femoral access or transapical access, and this try design as a non-inferiority. It means that it's equivalent or equal to the surgical AVR. You see that for the inoperable, the TAVI do very well and very effective in the mortality reduction. You can see that from 60% to 40% at 2 years. Yeah. It means that number needed to teach only 5. This is very, very effective treatment in terms of reduction mortality. When you go to the high risk arm, you can see that the graph is identical. It means that even you do TAVI or surgical AVR, the outcome is not different. And if you look into the transfemoral, it looks like a little bit better in the TAVI arm. It's 22% compared with the 26% in the surgical AVR at 1 year for us. That is for the balloon expandable. We go for the self-expandable platform like a core valve. They also enroll the high-risk patient, 70, 50, 75, 50 patients, randomized 1-to-1. And the outcome is not different from the partner trial. And you can see that it looks like the TAVI arm is a little bit low mortality rate when compared with the surgical AVR. If you enroll with, include the major stroke combined with the mortality, you can see that the TAVI is a little bit better than surgical AVR with a P almost significant, I think 0.046. Anyway, the risk in this group is quite high, but the proportion of the patient is quite small. Then we think that we may help you more. So we go to the intermediate risk patients. Study with the Planner 2A. Enroll a lot of quite big number of the patients, 2,000. As same design as the Planner 1, and divide into transfemoral or transapical, and randomized 1-to-1. The endpoint is primary endpoint is all-cause mortality or disability stroke. You can see that both graphs almost identical. No significant difference between TAVI or surgical AVR in terms of mortality and disability stroke. And if you look for the transfemoral only, it looks like TAVI is more benefit than surgical AVR. In terms of valve orifice, you can see that the TAVI gives us more larger area when compared with the surgical valve. Another study from the core valve is we call TAVI. Randomized about 1,700 patients, 1-to-1, TAVI or surgical AVR. The endpoint is the same. Mortality or disability stroke. You can see that the both gap is the same, identical. It means that you can do TAVI or surgical AVR. No significant difference between two groups. And you look only into the mortality only, it's the same. Disability stroke a little bit lower in TAVI group, but anyway, no statistical significant. The problem of the TAVI is the high incidence of new pacemaker implantation is 1/4 of the patient require permanent pacemaker implantation. However, if you go to surgical AVR, you face the problem with the atrial fibrillation, and maybe you need anticoagulant or something to prevent clot in the left atrium. And when you look into the pacemaker outcome, the patient receive new pacemaker is the graph in the white line. It's the same as the patient no need new pacemaker implantation. It means that the long-term outcome not different. It's same if you receive pacemaker or not. So that the pacemaker is not a big deal for the TAVI. So if we go to the biggest proportion, is almost 80% of the severe AS is the low risk patients. Do you think that this is possible? So this is the group from the Nordic country. Start with the TAVI in the low risk patients. Enroll the patient age more than 70 and one-to-one prospective. This study designed for the superiority time. Yeah, the N equal to 280. I think that the number is quite small. Maybe this is a early pilot study for the low risk. And randomized one-to-one, TAVI or surgical area. You can see that the graph is identical. It means that if we do TAVI in the low risk patients, the outcome is not different when you go with the surgical AVR. All cause mortality is the same, as well as the stroke, myocardial infarction, no different. As I told you that maybe the enrollment of the patient is quite small, so maybe you cannot see much difference between both techniques. However, you can see that the TAVI gives us more valve orifice area when compared with the surgical AVR significantly. It's made that the gradient between left ventricle and aortic valve is lower than surgical valve. The same, the pacemaker rate at 5 years is 40%. It's still high. And atrial fibrillation is the problem for the surgical AVR. And if you look into the pacemaker rate, compare with the patient need pacemaker or not, the long term at 5-year follow-up is no significant. It seems to be that the new pacemaker implantation is more getting worse than the no without pacemaker. Anyway, the p-value is 0.07, is not significant. Maybe the number of the patient is too small, as I told you before. And the problem of the TAVI valve is the aortic regurgitation. Anyway, if you look into the graph, the non or trace of my aortic regurgitation is not give us different when you have more or severe aortic regurgitation after TAVI. So in the future, they move to the notion 2 to declare the low risk patient is the outcome is TAVI should be superior or not, and follow with the partner T and US study for the low risk. I think in the next few couple of years, maybe you can see the outcome of this trial. In the low risk TAVI, this is published in the CCI this year. You can see that the only big study is the notion for the randomized trial RCT. But if you look into the registry data, they use the propensity match, but it's not as good as the randomized control trial. You see that the short-term mortality is not the same in the low risk. And for the long term, the TAVI seems to be less benefit than surgical ABR. But anyway, as I told you that this is the registry, maybe there is some selection bias in these patients. And the perioperative stroke is the same. And myocardial infarction is the same. The benefit is for the TAVI is the major bleeding is less. As you open the chest, of course you need the blood transfusion more than you puncture the groin. And the acute kidney injury during the operation is prefer TAVI. The less acute kidney injury in the TAVI group. Of course, the permanent pacemaker is the our problem, the only problem. But I told you that it's not a matter if you have a new pacemaker or not. And this is proposed by Dr. Martin Leong in the TCT meeting. You can see that the next 10 years, the incidence of the TAVI growth will be increased 4 times. It means that these patients will have, the low risk patient will go into this number. Because of most of the patients now, 80% of the patients are low risk patients. If you have to go up 4 times, then it means that low risk should be in this graph. For TAVI in Thailand, I will show our data a little bit. We start in Thailand, in the Siddharth Hospital, is the first hospital in 2009, and my hospital started the call in 2010. And in Ramatipdi, this is the biggest center to do TAVI at this moment. The case not so big, but more than 2,200 cases now. In our hospital is 100 cases over. We have data before TAVI era and 4 years after TAVI era. You can see that the aortic stenosis come to our hospital 100 cases for the 4 years before we start the TAVI program. But after that, the patients come to our hospital 2 times. It means that we do more aortic valve replacement as well as TAVI. We do the higher risk. In the past, before we start the TAVI program, the STS score is 2.6. But after TAVI, the surgical do more aggressive, do more higher risk patients. And 1/4 of the patients no valve replacement, maybe due to the not acceptable for the surgical or even TAVI. Yeah. And our TAVI is about 1/4, 26% of our aortic valve replacement. This is the reason of the patient who refuse replacement, valve replacement is about 50% refuse, and 1/4 is about a little fail, and 1/4 high risk, then the patient don't want to operate. and the outcome, the mortality is the same when we apply the TAVI program or previous the TAVI program. It's the same. And of course, if you do valve replacement, either TAVI or valve replacement, surgical valve replacement, the outcome is better than do nothing. It's definitely different. And in this study, the surgical valve, AVR, and TAVI is not different in the term of mortality. And if you look into the age over 80, it looks like the TAVI have better survival mortality at the 2-year follow-up. Anyway, the significance is cannot declare. This is our study presented in the Europe 2016 with the Hydra valve. This is a new self-expandable valve. This made in Thailand. We have accompanied with the Professor Sondergaard from the Copenhagen. And this made in Thailand valve. We hope that this valve may be cheaper than the market valve, maybe cut about 50%, and then we can available to do the valve because of the cost now. This design of the valve, it looks like the core valve, and it's the self-expandable. This is the positioning the valve, and before we complete deployment, and after we complete the deployment, we make angiogram to see that very trivial AR, and they give us the reduction of the gradient significantly. The problem is the pacemaker implantation, but a little bit lower than the previous one, only 14%. And the leak of the paravalvular leak, more than mine, is only 6.7%. But this study is, the number is very low, but just only 15 cases. But the new delivery system is quite small, and you can go with the 14 French without sheath. Maybe, and you can position the valve, completely capture and reposition if you don't want to position the valve. And how about the guideline? The guidelines say that this is from the ACC/AHA guideline. You can see that the inoperable surgical case goes to TAVI, definitely TAVI. And the high risk is the same, equal between TAVI or surgical AVR. But for the intermediate risk, they gave us only 2A, but the surgical AVR is class 1. But I would say that on the data we have, I would say that it should be class 1 as well as the high surgical risk. And the low risk may be class 2A. But now, no, in the class, in the low risk, just only surgical AVR. For the European, you can see that if the patient have low risk, they go surgical AVR. Other, you have to concern about the evaluation. If the patient have STS more than 4, you have more comorbid disease, age over 75, previous cardiac surgery, frailty, and less sticky mobility. So this prefer TAVI. Anyway, if you have to operate with the severe coronary disease, you have to bypass, you have mitral valve disease, you have tricuspid valve disease, you have ascending aortic aneurysm, you have to do with surgical AVR is better. And you have to concern about the anatomy and technical aspect as well. If the access site is a femoral, so it should be better to go with the TAVI. And in the case of chest radiation, porcelain aorta, we have some cases, the surgeon opened the chest and then close and send us for the TAVI. This is, you have to evaluate first, maybe use the CT scan, and now our surgeon make a recommendation for CT scan before surgical AVR to see the calcification in the aorta. And if you have a bypass graft in the chest, maybe go for TAVI is better. In our hospital, what is the recommendation for the aortic valve stenosis? If you have age more than 90, go for TAVI. Now, in some center, it's unethical if you do surgical AVR in the age over 90. And if the age over 80 and not low risk, TAVI and surgical AVR is maybe equal. It depends on the risk assessment, as I showed you previously. And if the patient low 80 and low risk, so we still prefer surgical AVR. It depends on risk like this, as I show you. This is data from the Copenhagen. You see that in 2012, the TAVI is about one half of the surgical AVR. But 5 years later, you can see that the number of TAVI is more than surgical AVR, and the age less and less. This is the data from our center. 2015, 16, 17, and 18. The number of AVR due to severe aortic stenosis is not so much. And compared with the TAVI, it's the same number. But this year, you can see that the number of TAVI go beyond surgical AVR now. We have every week, one case a week. Average cost of 3 months, we have 13 cases. So this is final slide for me. I think you can send the patient for us for TAVI and enjoy the sunny beach like this. Thank you for your attention.
Respected Chairman, ladies and gentlemen, let me first of all thank Dr. Pina Chani and Professor Yan for their kind invitation to this beautiful country. It's always very nice to be here. I hope it will come up soon. My task is to talk about the TAVI topic from a surgeon's point of view, and especially from a point of view to tell you that it is not for all aortic stenosis patients, and I can tell you I'm pretty convinced on that, and I hope that in the next few minutes I also can convince you. guess we have some difficulties here. I see my slides here, but they are not coming up.
There must be some TAVI proponents who are stopping from presenting your view.
Probably the cardiologist infected the computer. Okay. So, I'm absolutely convinced that this is a TAVI patient. One of our first patients in the old days when I've been in Frankfurt, a patient with a Euro score above 70, obese, old, plus a lot of comorbidities. I'm pretty convinced that this is a clear TAVI patient, 95-year-old lady, one of the oldest that we have ever done. The question is this a good TAVI patient? We all know that he had a Ross procedure 19 years ago, and actually in the last weeks someone decided to do a TAVI on him. It did not work out and he had to be reopened and had to have a conventional surgery. So let me tell you a little bit what's happening in Germany. These are our data, and our data in Germany are pretty complete because we are forced to send in and provide our data. And you see that TAVI, is this working? Yeah. You see that the growth of TAVI, this is the green here, is growing rapidly, and actually since 2 years we're doing more TAVI in Germany than conventional surgery. So at the beginning of this decade, we also started a register. It's a nationwide register. It's called GERI, and all of the aortic valve procedures go into this register. And you see that right now we have already collected almost 100,000 patients. The register is always 1 to 2 years behind in the data, and out of those patients, there were 33,000 isolated aortic valve implantations, 25,000 transvascular, and 7,000 transapical implantations. If you look at this data, then you see that the risk profile, it's not really surprising, is going down. This is the Euro score 1, still something that we have to rely on in our patient. It's going down, and also the SDS score is going down from 6.7 to 5.9%. How about the outcomes? If we look at the mortality, then this is going down as well from 5.9% to now 2.7% 2 years ago. And this, of course, is good news for the cardiologists. If we look at conventional surgery, aortic valve surgery, then we have a mortality, overall mortality of 2.3%. So that's not a lot lower than the TAVI patients. And this is a number we should remember. So Dr. Suphot has already told you a little bit about the guidelines. The ESC and EACTS, so the cardiologists and the cardiac surgeons in Europe work together. In these guidelines it says it should only be performed in centers with both departments, where there's a cardiology and a cardiac surgery department. It's recommended in patients at low risk, the conventional and the TAVI who have increased risk, and the decision should always be made by the heart team. We have already seen about the special anatomical conditions, short distance, size of aortic annulus, calcification, So there are various anatomical conditions where you should not do a TAVI. There's another specific issue in Germany that's called the Gemeinsame Bundesausschuss. This is a self-government of physicians, of hospitals, and of insurance companies, and they can make rules that are almost like laws, and hospitals and physicians have to stick to that. And the main law is that TAVI can only be performed in hospitals where there is a cardiology and a cardiac surgery, and they can only perform these procedures together. If they don't stick to those rules, they will not get reimbursed for their procedures. So, what do the cardiologists say? Cardiologists say surgery is invasive, patients want catheter-based procedures, heart-lung machine kills the kidneys, you have a long hospital stay, we produce low gradients, and our mortality is as low as yours. So let's look into that. We can do minimal invasive procedures as well. The scars are not too big. Even through a small incision, you have an excellent view at the aortic valve. So, in patients like this, do you think it is better to have no scar, or do you think it is better to have a long life? Heart-lung machine. We do know that the heart-lung machine makes something that's called whole body inflammation. And whole body inflammation does harm to your membranes, and your membranes do harm to the function of your organs and do harm to the function of your kidneys. So, of course, it is good if we could get rid of those heart-lung machines. But cardiologists also work with something that kills the kidneys, and that's contrast media. And if you look at the publications, and this is just one of them, it says, even though experience and techniques have constantly improved, kidney injury remains a major issue affecting outcome and survival. And I have to tell you, surgeons are not really afraid of dialysis, because we do know that kidneys do recover. What about the gradients? Yes, gradients in TAVI procedures are really low. One of the publications here from Italy, transcatheter valves seem to perform better in terms of transvalvular gradients and peak gradients. This is true. This might be true for most of the devices. But if you look at, for example, our experience with Ross procedures, and we do like Ross procedures over there, then you see they have extremely low gradients, but we could show that the left ventricular mass regression, and this is the thing that really matters, did not differ compared to procedures with higher gradients. So, if we look at mortality, first of all, I have to ask the question, why do we only look at the first 2 years? If we look at valve procedures, we should look out for 10, 15, 20 years. And when I talk to cardiologists, I always hear, well, we are as good, or our procedure is as good as your procedure. I believe we should turn this around, because if you take an invasive procedure that is as good as a minimally invasive procedure and has better long-term outcomes, which procedure do you think is the better one? So what do the surgeons say? The surgeons say TAVI produces paravalvular leaks, the pacemaker rate is higher, this has been shown extensively, durability is reduced, effect of radiation, that's a question, rate of endocarditis, something we also have to look into. Often, something I would like to add is an incomplete revascularization in patients with coronary artery disease. And finally, there's another issue I would like to draw your attention to. So, we all know those pictures. Implanted TAVI, nice function, but a paravalvular leak, usually always on this typical place. Here, implanted biological valve, perfect fit, no leak. We do know that paravalvular leaks do matter. There are various studies. If you have no or trace, or if you have mild or severe, then the long-term outcome is different. We could also show this in the Gary registry, where you have a big difference between severe paravalvular leaks, but also differences in mild trace and non-paravalvular leaks. Pacemakers. Even if you put in new valves, new technologies, pacemaker rate doesn't change a lot. And do you really want to put in a lady like this a pacemaker? It might be that the mortality is not different, but definitively the congestive heart failure, definitively myocardial function will deteriorate over time. Durability. Many of us know this first publication on long-term durability that was presented in 2016 in Paris, and that said that half of the transcatheter heart valves have deteriorated. Well, I could put in favor of the cardiologists something against this. We have presented our first decade of valve implantations, and we have 11 patients that are out there for more than 8 years that have no structural deterioration of their valve at all, but durability of biological valves still is an issue with or without stent. Something I couldn't tell you a lot of data about, but something we still have to think about is it good to put young patients, so low-risk patients are young patients, to an extended radiation. Something I have experienced lately in my department is that now the TAVI patients come back. They come back with endocarditis, and then to operate on them, because they usually have very severe endocarditis, it goes into the aortic ring, they have abscesses. To operate on those at their high-risk stage then is really difficult. What's also always impressive is when you take out those valves and then we look at the valve that still remains inside, it's always very fascinating how the blood finds its flow into the coronary ostia. And here you see this extracted specimen of a really heavily infected valve. One of the last points, we always have high-risk patients with coronary artery disease, what to do with them. And the issue I have here is, if we do surgery on them, we put them on a complete revascularization, we replace their valve. If cardiologists work on them, it is always an incomplete revascularization, because they always debate, this is not so important and that is not so important, let's do this one vessel and then it's enough. So this is also a downside of this procedure. And finally, here some pictures from my work. This is the Lüneburger Heide, this is the little city where I work, this is our hospital, and in this city, this is the pharmacy. And in houses like this, in Germany and also in Austria, you find those things. This might surprise you now why I start on this. This is called a farmer's cupboard. And you have this in various variations, and they from the outside all look the same. But if you look at the inside, then you have some that are worked in a perfect way. And then you have some that are worked like this. From the outside you don't see a difference, but from the inside you have a big difference, and it's all about precision, and you can be the best implanter and the most experienced TAVI implanter in the world. You can have made thousands of implants, but there's still a risk that your implant does not look like this, that it looks like this, because it's not perfect, because there's a calcification you could not calculate at the beginning. So this is really an issue, and only if it's 3, 4 or 5% of patients you cannot put a precise implantation. It's still the question, do you want a low-risk patient or a young patient to put to this risk? Don't get me wrong, I'm absolutely in favor of TAVI. You see here the first TAVI implantation complete sternotomy, transapical implantation in Frankfurt. It was in the year 2005. So I'm doing this already since a very long time. But please stick to the patients for whom this is made for. Let me thank you once again for being here, and let me end my talk with a picture I have been taking on Easter Sunday 2 weeks ago. Thank you very much.
Thank you very much. I think we have both cardiologists and cardiac surgeon on the ring right now. So, is there any question from the floor, any discussion or any comment? Yes, please.
ไม่ต้องห่วงเอ็มที่สอนลูกเอ็มเรียบร้อยแล้ว